Good morning, everybody. I'm Marvin Sih. I'm a neurologist, and I am also trained in sleep medicine. Um, I've been in university hospitals for about a little over 3 years now, and been in practice probably about 10 years out of training. Our talk for today will be about REM sleep without atonia, REM behavior disorder, and neurodegeneration. Okay, this will be a primarily clinical talk, and here's the outline. Basically, we're going to discuss about REM sleep without atonia and RBD, the association of RBD with neurodegeneration, and we're just going to explore some of the controversies and ethical considerations once you have a patient diagnosed with RBD. I do not have any financial disclosures. At the end, we will be discussing about some non-FDA approved treatment for this condition. Okay, so we'll start out with a case. This was a case I saw when I was a fellow. This is a 35-year-old male, so fairly young. He was referred by primary care for basically daytime sleepiness, sleep talking, abnormal movements during sleep. He supposedly kicks during sleep, kicks his wife. He does not get out of the bed when that happens. There was one episode he punched a wall, injured his knuckles in the process. He sometimes screams and sometimes wakes up mid-sentence and remembers his dream. He has had no recent weight gain or cataplexy or sleep paralysis. He also has had some personal history of celiac disease. This was confirmed. He had bilateral upper extremity tremor leftwards than the right since childhood. This has never been formally evaluated. And depression. He has some family history of epilepsy and tuberous sclerosis. At the time of seeing him, he was on amitriptyline and duloxetine with recent increases in the medication dose. He is non-obese, is Mallampati-1, and otherwise normal systemic and neuro exam, except there was some slight postural tremor, left hand more than the right, and normal tone. So basically, many of these patients, when they present to the sleep clinic, they're going to be presenting as, dream enactment behavior. Not that they will come with a label on their forehead, but it's something about what they're doing during sleep. Some patients, or actually families, might label this as sleep terror or nightmares. Again, these are terms usually used loosely by either the parents or the family, sometimes actually even by the referring physician. So they might come in with those chief complaints. Now, dream enactment behavior is not specific for REM behavior disorder, okay? Almost all, but not all of these patients with RBD will have a history of dream enactment behavior. Okay, however, the few that don't are diagnosed purely based on PSG. And we'll discuss that in a couple of slides down. This can also be seen in other conditions: untreated sleep apnea, sleepwalking, sleep terror, epilepsy, PTSD, alcohol or drug administration or withdrawal. So basically our talk today, it's going to fall under parasomnia. We're going to be focusing just on the RBD. We're not going to talk about, the other things. So REM behavior disorder, by definition, it's at least operationally from a diagnosis standpoint, it's characterized by both abnormal REM sleep electrophysiology. So you will have REM sleep without atonia, and abnormal REM sleep behavior, okay? And or a history of recurrent nocturnal dream enactment behavior that is thought to be happening during REM. Prevalence, the number that I got, at least for the UK population, was roughly about 0.5%. In some of the literature that I've reviewed, I think in the US, there was varying reports up to maybe 1%. The timing of the episodes usually reflects when the patient is in REM sleep. So normally this will be in the latter half of the sleep period, probably towards the morning hours, and tends to be in the few hours prior to wake onset. And the only exceptions to that would be in instances wherein your REM could be earlier, like say in narcolepsy, or when you have increased REM sleep drive, such as sleep deprivation or maybe untreated OSA. The frequency of the episodes can vary. Sometimes without treatment, it can happen every night, sometimes several times a night, sometimes once a week. Sometimes there would be months that this might not happen. It's just very variable for patients. And normally when they tell you that, it might seem that it could sound very random. Others might exhibit clustering, so they might have a couple episodes, and then for weeks or perhaps even months, they might not have one, and then it will happen again. And you know, these behaviors can lead to self-injury or lead to injuring their bed partner. So the demographics of these patients, usually they're mostly males, or a lot of them are males, about maybe 40 to 70 years old. And what do they do? What would they be presenting with? These patients might have abnormal vocalization. So they would be shouting or yelling about something, screaming, abnormal motor behavior, limb flailing or maybe punching, kicking, or rolling out of the bed for that matter. They could have altered dream mentation. And what's typical here is it involves a chasing or attacking theme, and the patient usually is the defender. Why that is the theme, I am not quite sure, but that's been what has been reported mostly in this condition. And usually the behaviors mirror the dream content. That's why it's a dream enactment behavior. And again, it tends to occur in the latter half of the sleep period. So let's talk about the ICSD-3 criteria, and all must be met. Again, repeated episodes of sleep-related vocalization and/or behavior. The behavior documented by PSG to occur during REM sleep, or again, based on clinical history of dream enactment, presumed to occur during REM sleep. There needs to be REM sleep without atonia on PSG, and it's not better explained by some other thing, some other condition. So a few things I found about this. So walking is quite uncommon with RBD. Leaving the room is quite rare. And patients usually, their eyes are closed, okay? It's as if they're attending to the dream action and not to the actual environment. The heart rate is normal, unlike in nightmares or, you know, that they might have some tachycardia. And in RBD, PLMs are often present without arousals during non-REM sleep, but it can continue into REM sleep, which is unusual in all other settings. And this is the diagnostic criteria from the online ASM diagnostic criteria manual. So basically, this is how you score REM sleep without atonia. So there needs to be excessive sustained muscle activity in REM, at least 50% of the duration of the epoch, with 2 times greater level of amplitude that's in the chin EMG. Or you can have excessive transient muscle activity in REM, which is basically about half of the epoch. In the limb leads, note that there is no, or at least not that I'm aware of, there is no minimum requirement of how many half epochs you need be able to diagnose REM sleep without atonia based on the limb lead, and any chin EMG activity that's at least 2 times the amplitude greater than the atonia level or the non-REM level. So if you have any of that, then you can say that there is REM sleep without atonia. Again, there's no minimum number of epochs as far as I know about. And, sometimes if the patient is asymptomatic and the REM sleep without atonia is the only finding, and basically it's an incidental finding on PSG, the significance of that is unknown. The few times that I've encountered that, I've reported it, but I didn't make a whole lot of, mess with it. So this is, remember that patient we talked about earlier, this is a hypnogram. This, by the way, is from our NK system back in training. So this guy had mild OSA, AHI is 6, REM RDI was 10, and PLM index is about 9. He had about 14% of REM sleep, which is towards the morning hours, and a microarousal index of 35. This is a snapshot of his PSG. I'm just showing some of the non-REM leg movements here, and note the chin tone and the leg EMG tone here. And this is actually his REM sleep. 1 hour epoch here is 30 seconds. So this is like, what, 5-minute screen here. And I'm just, what basically I'm showing here is, you see, like on this second hour epoch on your left, this is half of the REM sleep that, half of the epoch that had increased limb lead tone. And also this fourth one here. So there was increased phasic EMG tone, but the interestingly, at least for this patient, his chin tone remained low. So this would have qualified as REM sleep without atonia. This is a different patient.
Yeah.
No, go ahead.
Yeah, Marvin, I was struck by the idea that there's really no minimum length of increased tone in the chin during REM sleep. And on the other hand, when the fellows are looking over these records very, very carefully, we find a lot of non-REM atonias, or non-atonic REM, a lot of non-atonic REM.
Right, I didn't see anything. Let's go back here.
Yeah, I don't think there's a time.
50% of the duration for the chin. It has to be 50% of the duration.
Yeah, I guess so.
And basically for the limb lead, it has to be, 5 of the mini epochs, which is basically 50% as well of a 30-second epoch that needs to have the increased phasic activity in the REM.
Right.
What I found interesting is basically, even if you only had 1 epoch that satisfies that, technically, supposedly, you can,
exactly,
you can count as REM sleep without atonia.
Right.
Marvin, I don't know if you're going to bring it up, but I know there are some publications, I think in the last year or two, that tried to sort of look at that, what the minimum should be in order to be confident that this might be, a REM behavior disorder case.
I didn't come across that.
The other is on the example you have of the hypnogram. The one thing that I was, at one meeting I went to, they talked about, see that little kind of piano key in the middle of that REM period, that little white epoch of non.
Over here.
Yeah, right there. Is if you have that breaking up of REM. It used to be you would remember we had the 3-minute rule, and you would just, it would all kind all kind of white together. But now when you have a bunch of those in a REM, look around for it, because that may be an example of people misrepresenting what's REM sleep for wake.
Hmm.
So that's the other thing that's what I look at in a hypnogram. I'm just commenting.
Mhm.
Maybe you didn't run it. I'm not sure if anybody, has published on that.
Thank you.
Yeah.
Okay, so this is a different patient. I'm just showing how, what normal should look like, at least. Okay, low chin tone, and there's uneventful leg. There may have been some respiratory related arousal over here. And again, this is yet another different patient with what I thought was REM sleep without atonia. This is in a older lady with an unspecified ataxia without clinical complaints, but she has an undiagnosed moderate OSA. So again, she has had this increased chin tone, and here you have the increase towards the right side of your screen. We have increased phasic limb tone. Note that this is a four-limb EMG study as well that we used to run back in Chicago. So talking about diagnoses, there usually is diagnostic delay, and it could be up to a decade, if not more. The part of this is the patient not knowing that something, is happening. Of course, they're asleep. Sometimes their first notice that something is happening is, well, they're already on the floor and they wake up on the floor. In fact, I saw a patient about 2 weeks ago or so. He was coming in for Parkinson's. He looked like Parkinson's, but then as he was talking to me, he told me, well, you know what, sometime last year I broke my neck. Okay, well, that would have been the end of the story, but then I was just being nosy, I guess, and I asked, how'd you break your neck? Did you fall? Did you trip? Did you slip on ice? No, I was sleeping, and next thing I know, I was on the floor. And just that, he was sleeping alone. Next thing he knew, he was on the floor, and he had 2 of that, and he broke his neck. He literally had a neck fracture, and he needed to be on some sort of neck immobilizer. So anyway, to make a long story short, I'm working him up for sleep issues right now, possibly even RBD. He never had a bed partner. Usually the bed partner is an important influence with them seeking medical attention. Of course, if you don't have a bed partner, well, nobody's going to tell you unless you're aware somehow that something is happening. There are some cultural taboos about disclosure of what's going on inside the bedroom. Some of these might be chalked up to, oh, it's nightmare and he's done that forever. This is not something new, or an assumption that it could be related to substance use or any sort of supernatural or religious explanation. There could be also fear about law enforcement being involved, especially if there might be some sort of injury that is reported. Again, with the dream content, usually there's higher percentage of dream with aggression, and the patient is usually a defender. There seems to be more animal representation, and familiar characters are less common. So these could be like weird things in the dream content. Feeding or sexual elements are usually not observed in RBD. And in these patients, in as much as they could be, punching and yelling or whatever, doing these movements during sleep, there's usually no increased levels of daytime aggressiveness. And before I forget, just a quick fact. Sometimes in patients with Parkinson's who we see, they could be talking very softly during the daytime as part of their Parkinson's, what we call hypomimia. These patients, when they do have RBD, they could be singing, they could be talking, they could be screaming, and they're in their normal volume of voice, which is actually interesting. So you wouldn't, if they're not soft when they're not soft spoken when they're having these vocalization during sleep. So in terms of causes, and this is fairly important to be able to, at least for a framework in your mind, in terms of looking into this. So there's idiopathic, and there's secondary, or due to something else, basically. Idiopathic, as the name implies, there's no other known issues. However, the problem with that is, with the timeline of this condition, it may only be idiopathic now, but at some point it might develop, the patient might develop a neurodegenerative disease, or may not. For secondary, this can occur in neurodegenerative disease, could be narcolepsy, could be other things, and or medication associated, which we will discuss in the next few slides. Risk factors. This is a fairly recent article about 2 years ago now. There has been associations between possible RBD, dyslipidemia, smoking, pesticide exposure, and several prodromal PD symptoms. It's interesting that at least the smoking and the pesticide exposure, these are the same associated risk factors that have been reported for Parkinson's disease. There have been apparently some unreported links with family history of Parkinsonism or dementia, and CO poisoning as well. So let's talk about the secondary RBD. Okay, so most of these are going to be the alpha-synucleinopathy. This is not just, dementia in general, or, neurodegenerative conditions. Specifically, it's going to be mostly the alpha-synucleinopathies. What are these? And it's going to come up over and over again in any talk about RBD. This would be the Parkinson's disease, the Lewy body dementias, the multiple system atrophy, and pure autonomic failure. Other things that could be causing would be the tauopathies, which is not very common, at least as a cause of secondary RBD. So that would be your PSP, or progressive supranuclear palsy, and Alzheimer's dementia. Now, note that many of these neurologic conditions are not straightforward in terms of diagnosing. Okay, probably the Parkinson's disease, and probably the Lewy body dementia, and maybe the Alzheimer's. Those would be the more easier to diagnose in a neurology clinic, but the rest is, you're going to have to exclude other things, and well, maybe that's what we're dealing with here. Okay. So other secondary causes: narcolepsy, antidepressant use, paraneoplastic disorders, and brainstem lesions. So most recently, there have been the voltage-gated potassium channel antibody limbic encephalitis and Morvan syndrome, and the MA1 and MA2 autoantibody, and also the IGLN5 conditions that have been reported with associated RBD. Okay, so let's talk about the timeline when they're presenting. So if you want to look at late onset and early onset, basically the cutoff is about 50 years old. So most of the time, and this is sort of a rule of thumb, if it's more than 50 years old at the onset, it's usually associated with some sort of neurodegenerative disease. Again, it's the alpha-synucleinopathies. If it's early onset, okay, look at some other thing, at least initially. Okay, so narcolepsy, antidepressant, and idiopathic. And again, if followed long enough, they may develop neurodegenerative condition at some point. So this would be a very important slide and very useful slide to try to remember, especially when you're in the clinic. So antidepressant use, it's pretty much been reported with any of the major classes of antidepressants. I'm not sure why, the antipsychotics were lumped in this table, but they were. Most of the time, it's going to be the SSRI, the SNRIs, the tricyclic antidepressants that would be potentially contributing, if not causing. So if you're seeing somebody on that, like that patient, he was on amitriptyline and escalating dose of duloxetine, then that might be something, if able to, taper down or taper off, that would be one of the first things to do. And then let's talk about narcolepsy. By far, this is the most common cause of secondary RBD in early onset. So that's less than 50 years old. Okay, about a little over a third of narcoleptics have RBD, and about 60% of those with cataplexy had RBD. And about 38% of early onset RBD was secondary to narcolepsy. Again, this is the table of the synucleinopathy. There are some of the other tauopathies, including Pick's disease and corticobasal degeneration, and the FTD, and some of the other causes. Now, I just wanted to highlight here in the lower part of the slide, frequency of RBD in PD. Okay, it could be as high as 65%. In dementia with Lewy body, it's about 70 to 90%, and in multiple system atrophy, it's about 60 to 90%. So again, most common would be your synucleinopathies. All right, this what I'm showing here, this is a landmark, I would say, study by Dr. Schenk. This was back in 1996. This is in the Journal of Neurology. And this is a very elegant study in that basically he followed about, he looked into 29 patients. And in 1996, okay, when this was published, these patients at that point had what he thought were idiopathic RBD. And over time, 11 out of those 29 developed PD. This is more than 50 years old, okay, these patients. And what he found at that point was these patients have had elevated limb movement index, and somewhat increased stage 3 and 4 sleep, okay? So that's 1996. When he followed them up in 2013, okay, that's what, 16, actually no, about 16 years later or so, now 81% of those patients have Parkinsonism and dementia. 3 were lost to follow-up. Okay, again, going back, so that's 11 out of 29 in 1996. And then in 2012, there were 21 out of 26. Okay, this is in the what he thought was idiopathic RBD at that point. And he found that, again, it's the synucleinopathies that were mostly the cause or the diagnoses eventually. And the onset to Parkinsonism and or dementia onset is about 14 years plus or minus. Okay, so that's a long time. Again, we talked about the strong association with alpha-synucleinopathies, estimated risk of developing neurodegenerative disease in idiopathic RBD. In 5 years, it's about 17%, 10 years, about 40%. So in about 12 years, it's about half of these patients will or might develop neurodegenerative condition. So the other thing with this, it's interesting that I found is in alpha-synucleinopathy, the RBD typically begins years or decades before the onset of clinical cognitive and motor features, okay? And in the non-synucleinopathy disorders, however, the RBD tends to evolve with the cognitive and motor features or after. You know, again, I haven't really found this very useful clinically in terms of trying to diagnose, but, you know, at least in trying to think through things in your mind when you're seeing patients, this might be something that could be helpful. Clinical pathologic correlations. Again, the primary clinical diagnoses among those with RBD and coexisting neurologic disorders primarily would be the alpha-synucleinopathy, mostly the dementia with Lewy body, and the Parkinson's. The neuropathologic diagnoses, this is through autopsy, would be some sort of Lewy body disease and combined Lewy body disease and Alzheimer's. And with Lewy body disease, that will include the Parkinson's there. So among those, again, alpha-synucleinopathies would be the most common. And the association was particularly high when RBD preceded the onset of the other neurodegenerative features. What about screening? Okay, so I know there's at least 2 out there. I don't know that they're actually widely used clinically. Probably in research they are. So there's this RBD1Q developed in 2012, which basically it's a 1-question screening. If you've been told or suspected yourself that you've been acting out dreams. And then there's the Mayo Sleep Questionnaire developed in 2001. There's a patient version and a caregiver version. And it's been validated by PSG, and it's available free, apparently, for non-commercial use. So predictors of neurodegeneration, these are things that I found. These are predictors in idiopathic RBD about the risk of having neurodegeneration later. So there are testing that are involved. Again, clinically, these are not usually done, although you could do it if you had wanted to. So there are some vision testing, the UPSIT and olfaction testing, which is the BSIT. Interestingly, RBD patients will have about a third of them have impaired olfaction in about 5 years. Note that Parkinson's disease, and we'll touch on this briefly later, one of the preclinical symptoms that they have years and years and years prior to even manifesting tremor would be, impaired sense of smell. So it's interesting that, this is kind of correlating with that. There are some vision problems that are being complained to as well. There could be some subtle Parkinsonism, and there might be some mild cognitive impairment that could be picked up years before. But then again, you're not going to be diagnosing it RBD or even Parkinsonism just based on a finding of MC high on neuropsychiatric testing. So this is 2 graphs that I have found, which on the left is motor functioning, and on the right is the cognitive functioning in relation to advancing age. And if you can see, basically RBD usually will present early, okay, while you're still not having any motor issues or cognitive issues. And then as time goes on, as the patient advances in age, Then the patient might start having mild Parkinsonian signs, or maybe even frank Parkinson's diagnosis. And then the patient might start having cognitive issues down the road. Same with the cognitive functioning. RBD could happen early, and then over time, they might develop the cognitive issues. There could be some EEG abnormalities. We're not gonna go into the details of that and inspect abnormalities. I think this would be worth a few seconds of discussion here. So at least in the neurology world, now there is DAT scan that is available, which is a radionuclear testing that is very helpful in trying to distinguish tremors from being Parkinsonian and non-Parkinsonian tremor. I think this is actually what this is talking about. Basically, if you have reduced uptake in that radionuclear tracer, then that also could be a predictor of later neurodegeneration. And then you have PET abnormalities and symptoms of autonomic dysfunction. Again, we don't normally do PET scan on patients presenting in the neurology clinic. And then there's cardiac imaging that could be done. So I was looking at some of the articles about biomarkers. There have been some articles, but most of these are association about some variant in some gene loci with LAMP3 and BST1. Interestingly, the genes, the gene loci that are associated with development of Parkinson's, they haven't really shown strong association, at least with RBD, or at least right now. Okay, so pitfalls and RBD mimics. Again, this might look like some of the other sleep conditions. RBD would be here second from the right. Usually it's later onset, usually towards the morning, and it's REM. Okay, the only other thing that would happen in REM would be a nightmare. There's going to be a lot of motor activity in REM. Usually these are in older adults, usually. And what else? I thought there was tachycardia here somewhere, because usually in nightmares you would have tachycardia, but that's not really the case in RBD. And again, just as a reminder, you can see these RBD, what looks like could be RBD in other conditions as well. So going through pathophysiology, it's unclear, but it has something to do with dysfunction in the brainstem nuclei that modulate the REM sleep and the anatomical inputs. I have a picture later here. In the late 2000s, Brack and colleagues have proposed a staging system. It's actually a very nice study, at least in the field of neurology, because it tends to explain many of the timing of symptom onset for at least the Parkinson's disease and Lewy body diseases that we see. And this might be applicable to the timing of the evolution of RBD as well. Okay, I'm not going to bore you with all the structures here, but I want you to just focus here. So this is the pons. We're going to make it simple. Okay, and this is the medulla here. So you have centers there that are stimulatory to lower centers in the medulla. Okay, so these centers are supposed to stimulate the medulla. That's what should happen. Okay, this is normal on the right side. When these medullary centers are stimulated, they're supposed to inhibit the spinal cord tract, which should inhibit the spinal motor neuron, which technically should give you atonia. Okay, you're not going to move because the spinal motor neuron is inhibited. That's how things should be. Now, in RBD, it is thought that this pontine-mediated inhibition, so this doesn't happen. And so all these things down the line are not happening. And so that's why you have lack of atonia. Okay. I hope that I made that fairly simple there. So this is that BRAC staging that I was talking to you about. Again, we're gonna make this simple, but you see all these shades of black and red and pink and white here. So basically the darker color it is, that's where the pathology is thought to be happening the earliest. Again, this is through neuropathological studies. So these are autopsy studies in these patients. And, you know, it usually is in the lower medullary region that this pathology happens earlier. And then as the condition progresses, it goes up the pons, the midbrain, and then later on, before it affects the cortex, okay? I wanted to point out this, all right? So what is this? This is under the frontal lobe. This is your olfactory bulb and olfactory tract. It's black, okay? So here, so it's black, and it basically is one of the areas that are affected first. Remember what I said earlier, usually Parkinson's patients, by the time they're in your clinic with shaking, when you ask them, how's your sense of smell? Oh, I haven't been smelling well in like the last 10 years. So that's one of the things that are first to be affected. Which, going back to this slide, the anatomy, remember, the problem is in the pons, okay? When you lose that stimulatory signal, then you start having RBD. Well, guess what? The medulla and the pons gets affected early in the neuropathological course of this disease. And that also explains why RBD can be happening years and years before they even develop tremor, okay? And or they develop, frankly, cognitive issues. So I thought this was, you know, a very nice study. I'm going to spare you all this. All right, we're almost done. So treatment. So may be required for the following to prevent injuries in patients with violent dream enactment behavior, to decrease the intensity of unpleasant dreams, and also to avoid disturbing the bed partner's quality of sleep. So how do you counsel these patients? At the very least, you know, you need to be telling them of what could happen. You may roll off your bed, or you might inadvertently, you know, hurt your bed partner if you do have one. Need to make sure that you have safe environment, you know, clear the sleeping area, sharp edges, and those kinds of things. Physical barriers, bed rails, gates. I've had patients, I told them to put some of these up, or maybe even a separate sleeping area. Okay, the patient sleeps in one bed, and then maybe the bed partner sleep in another bed. There are bed alarm systems out there. I find that most patients don't bother doing these, or the families don't bother doing these. They're mostly into the physical barriers. These are the very, very least things that you should be telling your patients. And then pharmacological. Okay, by the way, this is obviously in the assumption that this is idiopathic RBD and it's not secondary to something else. Okay, obviously, if there's sleep apnea, you try to control that. If the patient is on antidepressant, that can be tricky. I usually what I do, I tell them, if you're able to get down on the dose or even get off the drug, okay, that might be helpful. We don't know what percentage of your condition could be related to your medication, but if you're able to get off of it, that would be great. If not, then we're just going to have to treat through it. Many of these patients, I don't just get them off of their antidepressants because they could be suicidal or they could be having psychiatric issues that are hard to treat, and they're in a good situation right now. And the last thing you want is really to disrupt that equilibrium. Okay, so just a warning. So these are non-FDA approved indications. So there's melatonin and there's clonazepam. Typically, I might start with melatonin, especially in the neurology clinic, when many times they're already on a lot of medications. And they could be more effective in patients with alpha-synucleinopathies and sleep disordered breathing. Now, if they don't respond to melatonin, or if it doesn't work for whatever reason, then something like clonazepam might be tried. And just a word of caution in using that in patients with dementia or gait disorders or concomitant sleep apnea. There are other medications that are reported to be useful. I personally haven't tried those things, but that's been out there. All right, the last part. Okay, so now what do you do? Okay, when you have somebody with RBD, or when you diagnose somebody with RBD, do you tell them? Do you not? How much do you tell them? Okay, so for years and years as a neurologist, that's one of my problems. It's like telling somebody that, hey, you have a BRCA1 mutation gene that might predispose you to developing breast cancer later. Well, first of all, that's more looked into, and second of all, that may or may not happen. Okay, so in RBD, in 2013, in the neurology literature, there was this article. I haven't seen any other newer articles after this, and I frankly haven't seen anything prior to this. It's titled "Ethical Considerations in RBD," and basically it talks about, do you disclose the risk of further issues? Okay, because RBD is the diagnosis now, but that has potential consequences for later. Again, we're talking about the neurodegenerative side of things. And then I think this is also what also plays a part here is, getting seen in a sleep clinic versus in a neurology clinic. Personally, interestingly, these patients, at least in a sleep clinic, they might be referred specifically for things that are happening during sleep, the movements. Okay, this could be young, this could be old, versus in a neurology clinic, that's not usually the complaint. Usually the complaint is something else. They have memory issues, or they are looking Parkinsonian, or they could be having tremor. And it's only on further probing and going further and further that, hey, you know what, this person might have RBD. Okay, so it's usually like 2 or 3 layers down the line that this is being considered. So, the arguments against disclosure, well, we don't know if and when this is going to happen. Okay, if you remember, 12 years out, the prevalence or the incidence is about what, 52%, I believe, on the number that I showed earlier. So that might cause anxiety and needless worry. Okay, and frankly, there's, not that I'm aware of, there's no treatment that currently exists to stop the progression. On the other hand, the arguments for disclosure, informed decision, seek second opinion, prepare for the future, watch for symptoms, and the fact that you're withholding something may harm the patient-physician relationship. As sooner or later, they might, learn about the risk. They might ask Google, or they might look it up and, hey, you know what? Why didn't you tell me about this? And basically what this article is saying, whether to break such news is not the question. It's instead, the question is when and how. And they're suggesting that the best approach is basically early disclosure and try to gauge how ready the patient might be currently, and how much they want to know or when they want to know. What I found is, in somebody who has Parkinson's, say I have suspicion that they are doing dream enactment behavior, and I'm wanting them, hey, you know what, let's check for sleep apnea, let's do a sleep study, you may have REM behavior disorder. By that time, usually that's like their number 5, problem down the list. The Parkinson's is what is up there, and that's what they're very much concerned about. And so I might just leave it at that for now, and I'll bring it up again, in the next visit. So this is a study from last year, and basically polled caregivers, and responses indicated strong preference toward receiving prognostic information. This is both for patients and caregivers. A majority of them felt knowledge about the disease risk was important, and that a prognostic discussion was important. And almost all of them indicated they wanted more information, and only a few did not. Okay, so in summary, we have a few more minutes here. RBD diagnosis requires clinical correlation with PSG to confirm, can be idiopathic or associated with other conditions. There's strong association between alpha-synucleinopathies and RBD. And again, RBD diagnosis potentially has implications that go beyond just a sleep nuisance and danger to sleep and others. And it's recommended that patients be made aware of the risk for developing neurodegenerative condition. And I underline risk there because it's truly a risk. It's not like it's 100% that that's going to happen. So having said that, so I have this patient who I read maybe about 2 months ago, the sleep study. I think this is a 30 or 40-year-old person. So as you see, this person has PLMs. This is non-REM sleep. But then it continued on towards REM sleep. How would you report that? What do you report it?